Glenn, you are muted.
Sorry.
Nope, that's okay.
Sorry about that. Hello, everyone, and welcome to the little chat we're going to have today. Everything that I present is based on facts and evidence, not on my personal opinion or hearsay. My background is as a researcher in healthcare, particularly in public health policy. So I will be apolitical and will not entertain discussions that are political in nature that at this point tends to divide us rather than unite us. So I want, because we are a Christian institution, I will invoke the blessing of John 3, 2:1, beloved, I wish above all things that thou mayest prosper and be in health, even as thy soul prospers. And that is the baseline for Christian education and Christian scholarly activity. So we, as a Christian institution, we are strictly evidence-based, but we use the Bible as our foundation and as our guide to align with the science that currently exists. So I'll just jump right into the presentation for the sake of brevity. Just going to share my screen. I hope everyone is seeing this. Excellent. So let me just see if I can move this out of the way here. And I probably can't. Anyway, so the idea is understanding healthcare inequality and what we can do about it. So people have decided we can do very little about it, but guess what? We can do something about this. So we'll soon see what this actually means and what the implications are, and all the drivers, at least some of the drivers of healthcare inequality, and everything is always behind the money. Okay, this started a couple of years back, more than 20 years back, about the IOM, Institute of Medicine, that did a landmark study about adverse consequences and how doctors were literally making a lot of medical errors and killing patients, literally killing people. And this is what started this whole radical shift towards, instead of looking at errors, but how do we promote safety? And the idea behind that is people should not hide mistakes, but try to correct them and share the knowledge with their peers so we can improve safety within the healthcare organizations, which the providers at that time cared very little because, of course, there was no consequences and no one paid money because doctors were the de facto kings and they ruled. So more than 20 years later, have we really built a better future? And the short answer is no, absolutely not. And you can see by what I put on the screen here by Naran El Agba. Today, a Black woman is 22% more likely to die from heart disease than a white woman. A Black woman is 71% more likely to die from cervical cancer than a white woman. A Black woman is 243% more likely to die from pregnancy or childbirth related causes than a white woman. So you ask yourself, what's causing all these negative things happening? And this is not just targeted towards Black women. It's more of a class and socioeconomic determinant that will determine whether you live or die, essentially, and how the balance of care lies in inequality and economic wealth distribution. US GDP spending on health. Okay, we spend more money on healthcare than any country in the world, right? Our nearest competitor in that regard spends about half. Canada and Britain and these other developed countries spend a fraction of what we spend on healthcare. In so much that Medicare spending per capita is significantly high in the United States, right? And we don't pay more because we have a higher healthcare utilization rate. So it's not about access or utilization, it's because of higher prices. And these higher prices come about because of systemic waste within the system, of administrative overhead for, let's say, administering reimbursement. It's insane that we have multiplicity of vendors and reimbursement systems that must meet the requirements of CMS, and some of them, they failed miserably, and these measures implemented to slow things down. So I suppose it kind of slows payments that go outbound, and it's causing a problem for our population. We spend a lot of money as healthcare, twice as much, and it's insane. It's not sustainable, and you'll see why. By 2028, it's expected that the healthcare spending in the US will reach nearly 1/5 of the nation's GDP. Healthcare expenditure will accumulate to about $6.2 trillion in total. This is not good news. It's not sustainable. It's killing us. So essentially, we have to change. Obamacare did a little to move the needle forward, but at this point in time, it needs a lot of tweaking, and we need to have some radical shifts in how we think about healthcare, and it should be systems-based and not what we see today. So healthcare providers, these are just headlines, and I'm just going to read a couple of headlines. Healthcare providers push to fix racism in the medical industry as COVID-19 devastates communities of color. Oh, so you mean there's discrimination in healthcare? You betcha. The direct result of racism. COVID-19 lays bare how discrimination drives health disparities among Black people. Another headline, structural discrimination in COVID-19, workplace protections. So I just picked COVID because that's the latest crisis we are going through. Every couple of years, the public comes upon crises that are ongoing, that has been going on for a very long time, that is always tamped down, and the public doesn't have a clue, right? Including disease surveillance and all what's going on in the community with all kinds of nasty strains of viruses that we never hear about until it turns into something big like a pandemic. Another headline, medical bias, from pain pills to COVID-19, racial discrimination in healthcare festers. And this is in the USA Today, posted in June 14, 2020. Racism and discrimination in healthcare, providers and patients. Our system is not built to serve everyone equally. Doctors push for an end to racial discrimination in healthcare. So all these headlines, I mean, if anyone wants to do, let's say, a simple research, you will find a lot of evidence that tells you, indeed, there's discrimination. There is a whole system, an ingrained system of systemic discrimination because it's institutionalized. Remember, doctors and nurses and the medical care provider system, it's made up of people. Guess what? And they're coming to the table with some of these implicit biases that you find that are exhibited and patients experience them. It's not imagined, it's real, and it's happening today with all the progress we have made. So, nice quote by Martin Luther King Jr. People fail to get along because they fear each other. They fear each other because they don't know each other, and they don't know each other because they have not communicated with each other. That is critical, right? With all the disagreements we see today in the political landscape and the polarization, we are not talking to each other in a language that's common, to say that we need a lingua franca, that we can speak to each other in a common language without, recriminations and hatred and anger simply because I disagree with someone or disagree with their ideological point of view. So how this perceived discrimination can lead to long-term patient disengagement and negatively affect intermediate patient-provider interactions. It happens. I've done a little research on personal one-on-one research about, I've interviewed people who have experienced this sort of discrimination and they had no idea it was discrimination, except they knew something was wrong and things weren't going well, and the doctor was not listening to them, or they were denied care and told, here's some ibuprofen, go on home, you'll feel better, right? And meantime, you could have a ruptured uterus. And mostly women complain about this, that doctor is simply not listening to me. And research has borne this out fully. So I'm going to jump to another big reason why this is happening, and it's because of social determinants of health. It may seem I'm jumping here and there, and it's because this is a broad and wide topic that it's not hard to get your hands around. But for the interest of time, I'm just trying to hit on these little points that encompass the entirety of discrimination and inequality in healthcare. So some of these social determinants are economic stability, neighborhood and physical environment. Remember redlining and what that means for certain communities, education, food, community and social context, and the healthcare system itself. And what's not there is financing. People are denied financing either for loans, or they're given outrageous rates when they should be funneled into rates that are more equitable with their white counterparts. And we see this causes a lot of stress to communities that suffer the brunt of this sort of integrated systemic racism. So the health outcomes of this mortality, morbidity, shorter life sorry, I gotta drink some water, sorry. Expectancy. Healthcare expenditures, health status, and functional limitations late in life. And guess what? We as a community, we all pay for this, right? We all pay. People think, well, I'm not paying. Yes, you are. We are paying through our private and public insurance funds, and our taxes go up as a result, and we keep paying. But we are all in this together, and we have to find solutions. So the social determinants of health, they pretty much revolve around where we live, where we are born, where we work, and how we age and where we age. They include factors like socioeconomic status, education, the neighborhood you live in, the physical environment, like the rotten house with mold that you cannot move out of because the landlord refuses to do anything about it. So we have these issues that impact health and longevity. The word I was couldn't, or life I keep struggling with this word. Why? Your life expectation, to put it simply. So increased recognition is that improving health and achieving health equity will require broader approaches that address these social issues that influence health. At the end of the day, if policies aren't changed in healthcare from a state and federal level, these issues will go on, and we will all keep paying and paying and paying. Not fair, because as a rich nation with so much wealth, and I was going to show a video about the 1% and the 2% and the wealthy and the poor, and how the poor and the middle class are so closely, you could hardly tell the difference between poor and middle class anymore because of these economic factors that we give to the rich, tax cuts for the rich, and let the poor and the middle class eat cake. I'm not being political here, but it's just that that's the reality on the ground. Being rich is good. Nothing is wrong with that. I'm not going to advocate that people bashing rich people or anything like that. God instituted these systems for good. Is how you use money. That's the impediment. So equality or inequality. So systemic and institutionally ingrained, or is it imagined? Are we imagining these things? So the preponderance of recent evidence, again, SARS-CoV-2 really, I mean, here's what, as a researcher, you are seeing these things daily, but when you try to discuss this with the general public, people tend, oh, you're an alarmist, you're poo-pooing this, and they kind of dismiss it. But here it is that SARS-CoV-2 exposed the weaknesses in our healthcare system. It exposed the great United States as being vulnerable to distress and disruption. It really hurt us in a way that it's not hard to recover from, but it did highlight the need for changes within policy, changes within financing and insurance of how we proceed to provide health care for all citizens in the United States, particularly those that are disadvantaged. So long-standing systemic health and social inequities have put many people from racial and ethnic minority groups at increased risk of getting sick and dying from COVID-19. So, and the figures from STAT, the CDC, from the Institute of Medicine, to the Minority Ombudsman, everywhere you look, the evidence points to, and Johns Hopkins is a great resource if you want to know about COVID, go to the CDC and Johns Hopkins, and even the WHO, despite their being vilified, they have a lot of relevant and timely information. So, COVID-19 cases as an effect of racial and ethnic disparities. So, we see in these figures here, particularly for minority groups, where in cases they're for natives, native peoples 2 times higher than the general populations, and the same thing for Hispanics. Blacks or African Americans 2.6 times, and Asians 1.1. So the death rate is what's shocking. With native peoples is 1.4 times higher than the general population. No increase for Asians. They seem to do a better job of protecting themselves. 1.1 times higher for Hispanics and Latinos, but 2.1 times higher for Blacks. Especially if you're put on a ventilator, people tend to die and not recover from being put on ventilators, as the research has borne out. Big shock and big surprise here. Yeah. So the idea that race and ethnicity are risk markers for other underlying conditions that impact health, from socioeconomic status, chronic health issues like diabetes, hypertension, obesity, hyperlipidemia, places you live, on and on, the job you do. Because the people who travel to and fro, back and forth, they go to their jobs because they're not working from home, are at greater risk of contracting COVID. The implications for upstream interventions and promoting equality and an egalitarian society lies in life course theory. So that is the whole idea of this theory is, in a nutshell, prevent the stuff from happening while your grandmother, let's say, this is epigenetics at its core and disease transmission. I did not want to use jargon or other words, want to try and stay away from that, so I minimized the use, but this is epigenetic theory, where people who suffer from micronutrient deficiency has shown a great preponderance of developing disease. The children, rather, when they're born into adulthood, it sort of pre-programs us because of genome influence. And every study has borne that out. At first, I poo-pooed that, and I said, how can this be? I was reading it from a guy named Dr. Wallach, Wallac. It's no representation, or he's not family, but he wrote a book called Epigenetics, the death of the genetic theory of disease transmission. I'm just looking at my bookshelf there, and it proves that one person may have a dissenting view, and it's always good to read those views, but the body of evidence points towards the view that more researchers are proving that there is a connection and a correlation between health, long-term health, and how our genes pre-program us through our DNA for the disease predisposition into adulthood. And if we don't change the way we do things, especially providing women and children care and good nutrition in their early developmental years, we're in for a world of trouble, and we will not break the cycle of disease transmission. So in a nutshell, that's what it is, to decrease these long-term effects on health and keep reacting and responding rather than being proactive. So I'm just going to ask Michelle if you can launch the first poll, please. And if I'll really appreciate it if people would answer this as quickly as you can and take a good stab at it. I'll just give it a couple more seconds. Okay, I'm in 10 seconds, gonna close.
We have about 50% voted so far.
Okay. I think we should end it at 1 minute, 30 seconds. That should be fair enough.
Hey, speak real quick.
Yes.
I do agree that the healthcare system is broken, bad, and it needs a massive overhaul.
Okay. But I'm going to ask you if you can hold your questions to the end.
Yes,
And yeah, and then I'll entertain those questions. Okay, or comments. Thank you. That's okay. It's okay, Carl. So the polling results, 92% agree for question 1. 1 person, 4% was neutral, and 1 disagree. So part 2, second question, 92% again agreed with just 4% agree, neutral and disagreeing. 63% agreed in live question number 3. 68% agreed, and 32% neutral. No one disagreed. And question number 4, 96% agreed, which is shocking. And didn't expect that. 4% neutral. No one disagreed. And the last one, unequal societies have higher incidences of chronic diseases, as in obesity, hypertension, mental health diseases, etc. So 80% agreed, 16% were neutral, and 1 person disagreed. So I'm going to jump back into this here. So thank you for participating in the poll. There's part 2 coming up, and I'll just run through this quickly because I'm looking at the time. I don't have much time again. So here are the correlations between, I call it just the chronic disease issues that we experience today. So, and this all comes about because there's a fantastic book called The Spirit Level, Why Greater Equality Makes Society Stronger by Richard Wilkinson and Kate Pickett. I will put that in the references. So if you want to get a copy of these slides, you will see where the research comes from, and you can look it up yourself. It's a fantastic book about equality and why societies suffer so much distress and upheaval and social issues because of inequality. That's the basis of social determinants of health and why we suffer all this inequity. And I've searched for this answer for 5 years. And at the end, when I was finished with all my core courses for my dissertation. That's what I discovered. Thank you very much, university, all this time and to wait to the end to let me know that. So anyway, so the wider the income gap, the wider the waistline. This is no joke. More than 2/3 of Americans are obese. The WHO classifies one being overweight with a BMI that's greater than 25 to 29.9 and obese at greater than 30. So 30 BMI. So the health consequences, which we all see, particularly for childhood obesity, which is what troubles me, because at the end of the day, if we don't break the cycle, we are having children that have a lower life expectancy than their parents, which is really troubling. Who's going to be alive to take care of old codgers like me, I wonder. So the idea is we want to keep these young people alive and paying into the system and make sure that they can work and produce and make America great again. Yeah. Okay. So in the late 1970s, half the population was overweight. Guess what? 15% obese. Presently, 3/4 of the population is overweight and close to 1/3 obese. In New York State, the reported prevalence of obesity in 2019 was 25 to 30% statewide. So, of course, there's a 95% confidence interval. So this means that this is pretty accurate, that we look around, more people are having positive energy balances and hence end up with being overweight and health consequences as a result. So, can we fix this? That's the question. Can we fix this? So the idea is, as Monique Telio said from the Harvard Medical School, each time I look at this quote, I laugh because this is essential. This is essential. Like I teach healthcare research, and even in participating in any research study, the first thing you need to do, of course, is identify the problem before you can even determine a problem statement and hence formulate a research question. So she says, articles addressing racism in medicine suggest many of the same things. To fight racism and discrimination, we all need to recognize, name, and understand these attitudes and actions. We need to be open to identifying and controlling our own implicit biases. We need to be able to manage overt bigotry safely, learn from it, and educate others. This is critical. So the idea is, yes, there are disparities. And what can we do about it? The first thing is look at yourself. Recognize what you're doing. I'm speaking to the healthcare providers here. Yes, people are burnt out and tired and angry and wondering why is this happening. But we have to take stock in the healthcare industry to understand, yes, we have a problem. People turn up at the ED and they're turned away or given scant treatment because people think blacks can tolerate more pain. Yes, even today, doctors still have that, misguided idea, and black women can take more pain. So why? You're a frequent flyer, I think. People show up with issues of sickle cell in extreme pain. Here's an ibuprofen or some painkiller. Go on home. It should get better. So the aggressive attitude, the aggressive treatment to distress is it's a real problem. So the other thing we can do is participate in grassroots organizations to lobby and advocate for change is essential. So it always comes down to what are we doing at the state, local, and hence compel a response at the federal level. Systems reform that is patient-centered and complementary to safety and equality, around reducing costs to optimize efficiencies and reduce billing overhead and administrative waste. That's what's sorely needed. In other words, systems thinking within healthcare is not there. We don't have a true system. We have a fractured bunch of pieces cobbled together that people are trying to pass as a healthcare system, and some parts of it are working in direct opposition to real care, where it's a continuum of care, where people don't drop the ball. It's gotten better now, but there's a lot to be done, because the idea of Obamacare was trying to change that, and the main focus was to restructure private insurance, expand Medicaid to the working poor, and change the way that medical decisions are made. In other words, hold providers' feet to the fire and make them accountable. The other big hurdle we have going on right now is interoperability, and that is being addressed. But if we don't have the political will, guess what? We're in huge trouble. So the bottom line is, what can we do to change this? Changing your attitude towards healthcare, changing how you interact with your provider, right? Make sure that your provider is listening to you and not brushing you off, making sure that you participate in grassroots organizations or contact your local representative in Congress or in Albany or wherever, and complain a lot. People respond to the squeaky wheel. If you don't complain, nothing changes. But do it, of course, in a respectful manner and not running up and down the street and making a ruckus. It achieves nothing. So that's what we can essentially do without being overtly political and causing any problems for people and actually getting people angry. So we all have opposing views and ideologies. We should decide. We can have a discussion without being disagreeable and listen to each other, and getting to know other people who don't have your point of view is essential for the United States to move forward. Countries like Sweden, I did not put up any fancy graphs, if you notice, about inequality and who is more equal and why it is so. And the nations that participate, that are more equal in terms of wealth and income distribution, have less health issues. In fact, they have better healthcare systems, despite the fact that we spend the most of any country in the world on healthcare and have the worst outcomes, from infant mortality to pregnancy, failures in pregnancy, and prenatal diseases. On and on we can go. And I'll just stop